This is the latest in our Contraception Access Learning Community ASTO Connects webinar series. In June 2022, ASTO launched the Contraception Access Learning Community through a grant from Arnold Ventures. And under this grant, ASTO provides technical support, capacity building expertise, and things of that nature to support states and territories as they navigate policy issues surrounding access to contraception, such as identifying sustainable funding, expanding telehealth, creating service equity, and supporting the state and territorial health workforce. Under this grant, ASTO produces webinars such as this one, as well as written content to support improved public health through advanced contraception access. If folks are interested in learning more about our learning community, you can visit the website on this slide that'll also be put in the chat. So we are so excited for today's webinar. Today's presentation is going to focus on supporting public health staff as well as their partners in learning key considerations and strategies for successfully integrating emergency contraception into their work. Through the states that ASTO is currently in partnership with under our learning community, as well as some of our state and national partners, we've heard through many working in this space that they have questions about the basics of emergency contraception as a contraceptive method, as well as the role that state health agencies can play in increasing access to this essential healthcare service. So today you're going to hear from subject matter experts about how emergency contraception works, as well as policy and programmatic considerations to EC access and examples of state and local initiatives that can increase access to EC. So next, I'd love to introduce you all to one of our presenters today. We are so excited to have Kelly Cleland, the Executive Director of the American Society for Emergency Contraception, join us today. Kelly and the Emergency Society for Emergency Contraception is a partner with us in this series. So this is part one of a two-part series that we'll be doing together on this topic. Kelly's background is in research with a focus on medication abortion and emergency contraception. Kelly is a fellow of the Society of Family Planning, a liaison to the Planned Parenthood National Medical Committee, and an editorial board member for the Journal of Contraception. As a reminder, participants can put questions in the chat throughout the presentation, which we'll try and answer at the end as time allows. And I'll now toss it over to Kelly.
Wonderful, Brittany. Thank you so much. And I am going to share my screen. And let's make sure we're on the right thing. We good?
Looks good.
Okay, wonderful. Thank you so much for having me here. I am just thrilled to present to you alongside Stephanie and Mandy to talk about what state health departments can do to improve access to emergency contraception. And before we start, I just want to know a little bit more about you all. So can you just let us know what state you're joining us from and what department, organization, institution you're with? So in order to use this, if you haven't used Slido before, you can just get your phone and scan that QR code on the top, and that will pull it up on your phone and you can answer the questions directly. If you don't want to do that, you can also go to slido.com and enter this code here at the bottom, 1589560. And we'll use Slido throughout this presentation to get some engagement from you all. So please, please join now. And I can see as people are starting to enter. Okay, we've got Texas, Ohio, oh, a bunch of folks from Alabama. Okay, Utah, Maine, Kansas, North Carolina, Colorado, New Jersey. I'm in New Jersey. Hi, New Jersey folks. Columbus, Connecticut, Texas, New York City, Arapahoe County, Iowa. We've got folks from all over the country. This is so exciting. For everybody who's in New Jersey, I'm in Mercer County, so I might be right near you if you work for the state health department. I'm probably down the road from you. This is really exciting. I love seeing this huge reach that ASTO has, and I'm so excited to be able to have this time with you all today to talk about emergency contraception, talk about your role in promoting access in your state. And we've got a couple of really fantastic presenters who are going to jump on with me after I finish my slides. They're going to talk about what they're doing in their own states, some creative ways that they are helping to increase access to emergency contraception. So I'm going to move on. I see we still have a couple of people typing, but this is amazing. I love seeing this huge geographical diversity. I bet we've got almost every state, if not every single state in the country. So wonderful. Welcome. I'm so glad that you're all here today. So today's agenda is, first, we're going to talk about the importance of emergency contraception and why we need to make sure that everybody has access to it. We're going to talk about options for emergency contraception and the basics of some of the medical stuff, safety, how it works, things like that. Because we want to make sure that you are confident going back to talk to your leadership, your constituents, your staff about emergency contraception. Talk about some of the barriers and opportunities. So there are lots of issues around access to emergency contraception. I will go back and forth between calling it emergency contraception and EC because it's a lot less syllables. So please know that if I say EC, I mean emergency contraception. And then finally, we're going to wrap up with a discussion of how health agencies can expand access. So first, let's talk about why access to emergency contraception is so important. The first thing I want to say is that emergency contraceptive pills are more likely to work the sooner that somebody takes them. So that means that any barriers, any delays can increase the risk of pregnancy. And you'll understand more about why this is the case when we talk about exactly how do emergency contraceptive pills work. But I want you to just, if you come away with anything today, I want you to come away with the knowledge that access to emergency contraception is very time sensitive. It is really important to get EC pills right away. So our job as people who care about public health is to make sure that as many barriers and delays are removed from the process of getting EC as possible. I also want to note that pregnancy prevention is more urgent than it's ever been. There are parts of the country where people are left without options if they become pregnant. And so we want to make sure that all pregnancy prevention options are available. Emergency contraception has a very specific niche in the contraceptive continuum because it's the only kind of contraception that is used after unprotected sex has already occurred. And this is particularly important for people who experience sexual assault. We need to make sure that anybody who experiences sexual assault can get emergency contraception right away without any kinds of interference. So there are things that can happen in the pharmacy, in clinics, and in health departments to help improve access for everyone, and in particular for people who have experienced sexual assault. Times when people use emergency contraception, sexual assault, certainly, if somebody has sex that they did not choose to have sex, that they didn't choose to have and they're forced. If somebody just doesn't expect to have sex that day and they do, even if it's consensual and they don't have any contraception. Sometimes contraception doesn't work. Sometimes you have a condom that breaks or slips. Sometimes you missed a few pills and you may not be sure if you're still covered by your pills. Sometimes somebody might have forgotten to replace their ring or their patch, or they're late for a depot shot. Those are all scenarios when people may need emergency contraception. And so we want to make sure that access is available for any scenario. Our organization, the American Society for Emergency Contraception, works towards a world in which everybody, everywhere has affordable access to emergency contraception with no barriers and no stigma. We are a very focused mission, but we work very broadly with partners across the sexual and reproductive health field to make sure that emergency contraception is becoming more available. So here's another poll. I'd love for you to just pop in here. What kinds of emergency contraception are you familiar with? It can be a brand. It can be a kind of, a kind of pill or device, a kind of medication, anything that you've ever heard of that can be used after sex to prevent pregnancy. Okay, we've got IUD, Julie, morning after pill, Plan B, Ella, hormonal IUD, great. Depo. The Depo shot has not been studied for use as emergency contraception, and neither has the NuvaRing. But there are some really exciting developments coming up that I'm going to talk about in a little bit. Yudspy, somebody gets a gold star for mentioning Yudspy. I'm going to talk about that in a minute. So excited. I just actually added that back to my presentation after doing a session for a bunch of medical students who brought it up. And I thought, okay, well, it's time to bring it back. And we've got lots of IUD. We've got a few different brands, My Way, Plan B, Julie, fantastic. Okay, so I'm going to talk about what are the different options for emergency contraception in the United States, and then we'll just get into a little bit more detail about what you should know about these options. So this is the Yudspy method that somebody mentioned that gets the gold star. This is basically using some pre-specified number of regular oral contraceptive pills as emergency contraception. So you would take, 5 or 6 as soon as possible, and then you take that same dose again 12 hours later. And there's a formula for how much levonorgestrel and how much estrogen that you need to get in each dose in order to have it work as emergency contraception. This is sort of the original emergency contraceptive pill. Before there was an actual Plan B pill that was dedicated to emergency contraception, this was what was used. It is, in some cases, just regular old oral contraceptive pills may be more available. If there are new restrictions on emergency contraceptive pills, this might reemerge as a good option for folks. The downside, of course, is that combined oral contraceptive pills are prescription only. You may have heard that there is a new oral contraceptive pill that was just approved by the FDA. It's called Opill. As of now, we don't think that it is recommended for emergency contraception because it is not the right kind of hormone. But you can use other kinds of oral contraceptives. This method is not the most effective. This is the least effective or emergency contraceptive method. And it has more side effects because it contains estrogen. So when you're taking a bunch of pills at once that have estrogen in them, you're going to get more nausea, more headache, that kind of side effect. So this is not the one we recommend, but I want to make sure that you know that this is a possibility because it may become more important in the future. This is the one that most people have heard of. Plan B and its many, many generics are made of levonorgestrel. It is available over the counter with no age restriction, which is really, really good news. It has been available OTC for about 10 years without age restrictions. There has been a long and dramatic history in the United States with the regulatory situation of Plan B. And so it's very confusing in a lot of cases. And a lot of pharmacists are still unsure if they should ask for ID, if there's still an age requirement. There's not. So in general, Plan B, and as I said, there's probably 20 different generics of Plan B. There's My Way, Julie, Opsicon. There's just so many, and there are more coming. This is generally the easiest to get because it's OTC. There are barriers to access, and I'm going to talk about those in a little bit. It is less effective than the next 2 options that I'm about to talk about, but this is a really solid option, and I want to make sure that we all keep this in mind as an important option for EC because it's the most common by far. Ella is another emergency contraceptive pill. The downside of Ella is that it is prescription only, and it is not always available. So Ella has been on the market in the United States since 2010. And by now I would have hoped that it would be much, much more known and much, much more available because it is the most effective emergency contraceptive pill that we have. I'll talk exactly about why it's more effective than Plan B in a little bit. But what we have found is that healthcare providers don't always know that this is an option, even so many years later after its approval. Pharmacies often do not stock it. So there have been several different studies that have looked at pharmacy availability of Ella, and it seems like about 10% of pharmacies keep it in stock. which is extremely, it's frustrating for somebody who walks in with a prescription for a very time-sensitive medication, and then all of a sudden they are told that there is no Ella available to be dispensed that day. Okay, and so finally, we're going to talk about the last option, and this is an IUD. So I've got, if you know your IUDs, you'll note that I have both a copper IUD on the right with the sort of darker stem, and I have the Mirena, or the 52 milligram levonorgestrel IUD here on the left. Both of these IUDs, so the copper IUD has been studied for 30 plus years. It has been used for decades as an emergency contraceptive. It's very exciting. This is almost 100% effective. You can get an IUD, a copper IUD inserted, keep it. Now there's evidence that it can work for 20 years to prevent ongoing pregnancy. So this is a really fantastic option for someone who wants ongoing contraception. There's new evidence that has come out within the last year or so that the levonorgestrel IUD, like Mirena, can also be used as emergency contraception. This is really, really exciting because for many users, the Mirena IUD is much more acceptable than the copper IUD. That's not the case for everyone. Some folks really want an IUD that has no hormones. And in that case, the copper IUD is a great choice. But for somebody who, for example, has heavy periods and wants to have lighter periods, maybe wants to have no periods, the Mirena can really, really be helpful with that. So the downsides, of course, are that it requires a healthcare provider to get an IUD. We don't yet have any self-insertions of IUDs, although there have been studies about self-removals of IUDs, which is very interesting. For some patients, the insertion process can be difficult, especially for those who have not yet had given birth or been pregnant. So that's, counseling points to talk about, but I think in general, especially in places where the stakes for preventing pregnancy are extremely high, I think it is really, really valuable to make sure that this is available as an option. And as I said, these are by far the most effective options. The newest thing that is being studied that I'm hoping that we're going to know more about within the next year is using the implant as an IUD, because there is some evidence that the implant, when provided after unprotected sex, can also suppress ovulation. So that is extremely exciting, because the implant is, kind of a halfway point for a lot of folks. It's a long-acting method, but it doesn't require, anybody to get up in stirrups and have pelvic, anybody like doing any pelvic exams or anything like that. It can be a lot more comfortable for people who want maybe a long-acting method, but don't want to deal with an IUD insertion. So a lot of exciting options here. I want to just also make sure that everybody is really clear. Emergency contraception is different from medication abortion. These are two different things. So on the left here, emergency contraceptive pills. These are two different formulations, as I talked about. Levonorgestrel is Plan B. I've got a few other options here, a few other brands. Julie, My Choice, Option 2, My Way, Next Choice. There's lots of those, all over the counter, all available at the pharmacy. Ulipristal acetate is Ella. This is the one that I said is prescription only and more effective. But these are used after sex. This is contraception, okay? It doesn't work if someone's pregnant. It doesn't affect a pregnancy if someone either takes it not knowing they were already pregnant, or takes it and then becomes pregnant. It doesn't do anything. It works by preventing ovulation. So this is a contraceptive. Medication abortion, on the other hand, there are two drugs that are typically used in the medication abortion regimen, mifepristone and misoprostol. These are approved to end pregnancy for up to about 11 weeks. There's evidence that it can be used actually longer than 11 weeks. But this is an option for someone who is pregnant, has a positive pregnancy test, and does not want to be pregnant anymore and wants to end the pregnancy. Emergency contraceptive pills will not do anything for a person who's pregnant and doesn't want to be pregnant. So I just want to be super, super clear that these are different things. They do different things, and they're for use at different points. Questions about safety. So one thing to know, emergency contraceptive pills are incredibly safe. So, thinking about many of the OTC drugs that are on the market, like Tylenol, for example, there are a lot more safety concerns with Tylenol than there are with levonorgestrel emergency contraception. So, anybody who says they're concerned about safety, there is no medical safety issue when it comes to levonorgestrel. I've mentioned this already, but I'm going to say it again. Emergency contraception pills will not harm or end a pregnancy if someone takes it and they're already pregnant. The side effects of emergency contraceptive pills, they could include nausea, headache, changes to the menstrual cycle. They're usually mild and they usually just pass on their own. The cycle changes can be a nuisance because you don't really always know how it's going to go. The cycle your next period could be earlier, it could be later, it could be shorter, it could be longer. So that's a little bit of an unknown, but it will typically go back to normal the next month. Emergency contraceptive pills can be used multiple times, whether it's in the same year or even within the same month. There's not a safety concern about that, but it's not as effective as an ongoing contraceptive method. So if somebody finds themselves in a situation where they're reaching for Plan B multiple times a month or multiple times a year, or they're getting Ella on an ongoing basis, number one, it's going to be really expensive. And number two, it's not going to be the most effective method. So for people who are highly motivated to prevent pregnancy, we do really recommend considering an ongoing method. And there are so many options to choose from for ongoing birth control that I think most folks can find something that works for them. But EC is a really, really important option. And for folks who need it, we want to make sure it's always there. We're going to talk a little bit about how emergency contraceptive pills work. And so I first would like you to just check, this is a check all that apply, so you can choose as many options as you want. How do emergency contraceptive pills work? Choose each one that matches your understanding of how these pills work. We've got a few folks still answering. Love to hear from everybody on this if possible. One of my big hopes, in addition to making sure that everybody knows that emergency contraception is time sensitive, also want to make sure that folks walk away with a really clear understanding of how emergency contraceptive pills work. So we had the majority of people saying it prevents ovulation, the release of an egg. We've got also a large group saying that it prevents a fertilized egg from implanting. A few said keep sperm from entering the body, and then a smaller percentage said disrupting an embryo that is already planted. So prevent ovulation, release of the egg, that is the number one mechanism. That is the way that this works. Preventing a fertilized egg from implanting, there is actually no evidence that that is how EC pills work. But it's confusing because that language has been on the product label for a while. And we'll get into that a little bit deeper. Other contraceptive methods do keep sperm from entering the body by changing the consistency of cervical mucus, but emergency contraceptive pills don't work in that way. And disrupting an embryo that's already implanted, that's what medication abortion does. If there's an implanted embryo, which is how we define a pregnancy, emergency contraception will not do anything in that case. So I'm going to show you some pictures. This is like, 8th grade science class. I have a 9th grader who took biology last year, and she probably saw something like this. So what I want to call your attention to, I'm not going to get into too much detail on this very complicated chart, but let's look at this line in the middle. There's a black line where it says ovulation, and there's something that looks like an alien eyeball popping out into the screen. That is ovulation. That is the necessary step for pregnancy to occur, right? Somebody has sex, there's sperm in the body, in the vagina. The sperm will travel up through the fallopian tubes, and then they're going to hang out for 5 days. After 5 days, sperm are no longer viable. So in all of these EC discussions, we talk about whether something is effective for 5 days after unprotected sex. That's why we care about the 5 days. Because after 5 days, sperm aren't viable. We don't care what happens. So we want to prevent ovulation after unprotected sex. So when those sperm are in the body, we want to make sure that we do everything we can to keep the egg from coming out. If the egg never comes out, the sperm are just going to die. They're going to get flushed out of the body, and then we don't have to worry about pregnancy. The red line that says LH, that is luteinizing hormone. That's the hormone that kicks off ovulation. So for anyone who has tried to become pregnant, you know that these days of the cycle, it's around day 12 to 14, when the luteinizing hormone surge starts, that's when you want to have sex, because you want to make sure that there are sperm there ready to fertilize the egg when it comes out. If somebody does not want to get pregnant, that is when you want to avoid having sex. Or if someone has already had sex and it's close to this time, you want to try to interfere with that luteinizing hormone surge and prevent ovulation. And that's what emergency contraceptive pills do. This timeline, this is just something that I made. This is not to scale at all. So if you're a doctor, don't come at me. But it's just meant to illustrate the different events that have to happen in order for pregnancy to occur. So first, we have that luteinizing hormone surge. It begins about 12 hours later, it peaks, and that kicks off ovulation about a day after that. Once ovulation has occurred, if sperm already are in the body, they will fertilize an egg. And then the fertilized egg will travel through the fallopian tube. It will take about 6 to 12 days. And then about 35% of fertilized eggs never implant at all. They just get flushed out of the body. Those that do implant, once the fertilized egg is successfully implanted, that is when pregnancy is established. So Plan B can work before that luteinizing hormone surge ever begins. So if you take Plan B before that surge has started, you can stop that LH surge, and then ovulation won't happen. So that means all of these events after that first black line don't happen. Ella is more effective because it is still able to prevent ovulation through that next 12 hours between when the luteinizing hormone surge begins and when it hits its peak. That's that time when you want to, if you're trying to get pregnant, that's the time when you want to have sex right there. So that's like the most risky time of the cycle if you don't want to be pregnant. So Ella is super important as an option because it still works in that critical stage of the cycle. So again, Ella, it can work up to that point, prevent ovulation, and then none of these other events will happen. There will be no ovulation, no fertilization, and no implantation. There is a lot of confusion because of what the labels say on these products. So the Plan B label, up until, just a few months ago, said that it could prevent attachment of a fertilized egg to the uterus. This language was not based on science or evidence. This was based on some assumptions. It was based on some old ideas about how oral contraceptive pills might work. But there's never been any evidence to show that this is how it works. And unfortunately, this language has been used to prevent access to emergency contraception because it is interpreted as, oh, if it can prevent implantation, that means it's an abortifacient. It's still not an abortifacient. Even if it could prevent implantation, it still is not working after pregnancy is established, but it created a lot of confusion. In December 2022, a new label was approved that now aligns with the evidence about how EC pills work. And starting in 2023, all of the new labels for levonorgestrel emergency contraception will have that language removed, so it matches the scientific evidence better than the old label did. Quickly, I'm going to talk about efficacy of emergency contraception and body weight. This is another confusing area. There is some research that suggests that emergency contraceptive pills could be less effective for users that have a higher body weight. The evidence is not great. As a researcher by training, I wish that we had much more compelling, clear evidence, but we talk about this because the stakes are really high. In the United States, more than half of the population of women of reproductive age weigh 170 pounds or more. If you look down here underneath Plan B, one step here, it says may lose efficacy after 165 pounds. So that means if someone weighs more than 165, it's possible that Plan B might not work. If we're talking about Ella, it also seems like it has a limit of efficacy, which could be 196 pounds, or a BMI of 30. I prefer to talk about weight just because most people don't know their BMI. The IUDs work at any weight. These are a more effective option for anybody at any weight. So what we say about this is for patients that have higher weight, we recommend Ella or an IUD. If those are not an option, we still recommend that folks take Plan B. I'm not a doctor and I'm not giving medical advice. However, I think, there's some consensus in the medical community that it's better to take Plan B than to do nothing. I am hoping that we will get some more effective, some more convincing evidence about this question so we can really know for sure. But right now, we just don't really know. Let's talk about how many women in the United States have ever used emergency contraception. Take a guess, or if you know, please say, please choose the answer that you think is right. But what proportion of women have ever used EC in their life? And this could be one time when you were 14 years old. This could be every month, just at least one time. And I'm going to show you some data from the National Survey of Family Growth that is kind of the best evidence we have about contraceptive use in the United States. Okay, so most folks said 45%, and about equal proportion says 71% or 25%. No one thinks it's as low as 10%. So in the latest survey, it was 25% who have ever used emergency contraception. We don't know if they're talking about Plan B or Ella, so that's a bit, unclear from the National Survey of Family Growth. But we can see that it's increasing by a lot. When you look at this on the 100% scale, you can see that there is still a lot of room for growth here. So I'm hoping that improving access to EC throughout the country through health departments will improve this. If this number were low because everybody was already using a fabulous contraceptive method that they're happy with, great. But I don't think that's the case because the unintended pregnancy rate in the US is still quite high. One thing we do at our organization is monitor access to emergency contraception in pharmacies. We did a study last summer of 313 stores. Folks went in person in 21 states to see what it looked like in the pharmacy to try to buy emergency contraception. 18% of these stores did not stock emergency contraception at all. 27% imposed age restrictions. And I'll remind you again, there has not been an age restriction on Plan B or its generics since 2013, 2014, so it's almost 10 years. 46% of stores kept emergency contraception behind the pharmacy counter when it should have been on the pharmacy shelf. And then 80% did not have Ella in stock. So these are all really important barriers. If you are talking about a product that needs to be taken as soon as possible to be effective, we need to really help knock down these barriers. Price is another huge barrier to EC. These were some findings from our last survey. And I have these highlighted in yellow down here because these are the prices for generic EC. The range is really quite mind-boggling. The low that we found, this was in an independent pharmacy or a grocery store, $5.18, but then it was sold at a high of $54. So this tells us, A, emergency contraception is really cheap to make, levonorgestrel, like the Plan B kind, and sometimes it costs way more than it needs to. Over here, Plan B costs $64 in one of our stores. There is no reason for this product to cost this much when we see it being sold for just over $5. Barriers to access include limited clinic hours, the transportation and distance. If you particularly live in a rural area and you need to get to a pharmacy or a clinic that's far from your home, the cost is exorbitant and really out of reach for a lot of folks. In some cases, stigma and embarrassment are a really important barrier because they just might feel uncomfortable. If EC is kept behind the pharmacy counter, they may not feel comfortable going up and talking to a pharmacist who may ask them for ID, who may refuse to sell emergency contraception to them. Some changes in policy that have improved access to emergency contraception in the last couple of years. There's been a lot of movement to improve access on college campuses. Our organization does a lot of work on this front that I'll briefly discuss. There's also been some more policies that have restricted access to emergency contraception. Some of this is related to confusion about whether abortion bans apply to EC. Some of this has been about, for example, in Iowa, they stopped providing EC to sexual assault victims. And that is incredibly problematic because folks who have experienced sexual assault really need access to EC. Our campus organizing project is called Emergency Contraception for Every Campus. We work with 169 campuses across 38 states. Most of them are publicly funded, and a third of them have a graduation rate below the national average, so that can really indicate a high need student population. These are some of our student leaders. They are doing incredible things. Some of them are handing out emergency contraception to each other because it's an OTC product. You can do that. Some of them are helping to get approval for emergency contraceptive vending machines on their campus, where students can get emergency contraception in a machine 24/7. In emergency contraceptive vending machines, in vending machines that are focused on health and wellness, certainly emergency contraception is a great option. We also recommend that people include pregnancy tests, UTI tests, condoms, lube, menstrual cups or other menstrual products, general health products that folks might need, and also harm reduction supplies like Narcan, like fentanyl test strips. On college campuses as of now, we are aware of 40 campuses that have vending machines that include emergency contraception. There's about to be a lot more in Illinois and in Maryland because these states have legislation in place that will require that all public universities offer 24/7 access to EC. We'll see a lot more in Washington State and in New York as well. These are some of our students. I just like to show them off all the time because they are so incredible and so bold. I would love for you to connect with us. I think you're going to get these slides afterwards, but please find me on LinkedIn, send me an email if you have any questions. Would love to connect further. And I'm going to stop my share because that's the end of my slides.
Thank you so much, Kelly. We are going to actually roll right into our next section just for time reasons. And then if we have time at the end of our panel discussion, we'll circle back to any questions for Kelly. And yes, we will be sending these slides out and the recording to anyone who registered. So you'll find Kelly's contact information as well as our contact information there, and our next two panelists' contact information as well. So if your question can't get answered today, feel free to reach out to any of us. And I'm sure we'll be happy to find that answer for you. So without further ado, Kelly, I'll toss it over to you to introduce our next two panelists.
Fabulous. Okay, this is such a total honor for me to be able to present alongside Mandy Fleming and Stephanie LeBleu. Mandy is a Title X family planning manager with over a dozen years of experience in sexual and reproductive health care. Her true passion lies in destigmatizing sexual health and ensuring equitable access to high quality sexual health care for all. With a unique blend of passion, witty humor, and unapologetic realism, Mandy actively works to deploy innovative projects and services in the conservative corner of Northwest Montana. She firmly believes that if she can implement progressive projects in her community, it can be achieved anywhere. So Mandy, thank you for being here. I'm so excited to hear more from you. And Stephanie is the Everybody Texas Title X Project Director. She leads the nation's largest Title X project and lends her 12+ years of experience and expertise in the field of sexual and reproductive health to ensuring all aspects of the Title X project function in support of providers and the clients that they serve across Texas. In addition to Title X, Stephanie also established and leads the Everybody Texas's EC for Everybody project, which distributes free emergency contraception to people across Texas for free. So thank you so much, Stephanie and Mandy. I am up. Oh, we lost Mandy. Oh no, I hope she's not having technical problems. Stephanie, I'm going to start with you. So I'd love for you to just first talk about the context where you live and work. So what is the landscape for contraceptive access, including EC, and more broadly for reproductive rights? And are there unique challenges that people who need EC face in your state?
Hi, everybody. Thanks, Kelly, and thanks to ASTO for having me today to talk about EC in Texas and the work that we're doing. I'm sure a lot of folks on this call are aware of some of the situations that have come out of Texas, the restrictions, obviously surrounding abortion care, but drilling all the way down to accessing EC and other types of contraceptive methods across the state. And so the landscape is bleak in Texas, if we're being honest. Texas has a really long history of creating restrictions and prohibitions around specifically abortion. And then, of course, I think folks are most recently familiar with SB 8 that came out in 2021 that restricted access to abortion up to around 6 weeks, and also made it possible for private citizens to sue folks for aiding and abetting or providing abortion care. And then, of course, post-Dobbs, Texas does have a trigger ban, which makes abortion illegal essentially in the state. But drilling down from there, Texas, we have a number of different state-funded family planning or sexual and reproductive health programs that the state funding does go towards. But those do not fund or pay for or reimburse for emergency contraception. Another thing that's kind of interesting and seems to have kind of begun and grow across the state over the last few years are what folks have been calling in the anti-abortion space sanctuary cities for the unborn. And so these are localities, municipalities, cities across the state who have attempted or been successful at passing local level rules and regulations prohibiting abortion access. But some of those have gone as far to try to prohibit emergency contraception as well. My role here in Texas and at Everybody Texas, the organization I work for, is to oversee the funding of the Title X program across the state. And so we fund about 150 or so Title X funded clinics, and most, if not all, of those providers do provide EC to the communities that they work in. But we do have some issues around finding providers that, especially in smaller or more rurally located geographic areas, who want and are comfortable with providing emergency contraception through their program. And so I would say those are kind of the intersected troubles that we have in providing emergency contraception across the state.
That's helpful, Stephanie. And I think, one thing we find everywhere is that these barriers are intersecting and overlapping and multiplicative, right? They add on top of each other. Mandy, welcome back. Would you talk about the context where you live and work? What's the landscape for contraceptive access, including EC and reproductive rights more generally? And then are there unique challenges that people in your state who need EC face?
Sure. So I'm currently based at the Flat City County Health Department, and I manage a Title X family planning clinic in Northwest Montana. Where I live is pretty conservative, and folks who are decision makers for our county and our county health department definitely fall into that category. So for example, our Title X funding went in front of our county commissioners this spring, and 1 out of 3 county commissioners voted it down because of the fact that we offer emergency contraception. So there are a lot of issues for us to promote access, for us to distribute it, for us to advertise for it. And on top of that, we live in a very rural area where a lot of folks can't get to the nearest Title X clinic, and we have a lack of public transportation. So getting the word out with EC or letting people be able to access it has been quite the struggle here in Flathead County. So we're trying to find creative ways to make that happen.
That's great, thank you. And so on that, Mandy, let's stick with you. What is your organization doing to address the need for emergency contraception? Who do you partner with? What makes your program work?
Sure. So one of the most exciting things we've done in the past couple of years is implement a vending machine here at the health department. And we call it a harm reduction vending machine. So it really stemmed from the fact that we have a syringe exchange program and folks needed access to syringes, Narcan, et cetera. And then we just capitalized on that vending machine to offer emergency contraception for $5, condoms, and other sexual wellness products. We also have snacks in our vending machine. So when folks go to use it, we don't know if they're purchasing a candy bar or if they're purchasing condoms. So it kind of creates some confidentiality there. Also, being in a small town, a lot of folks don't want to go to the pharmacy because they may know the pharmacist, they may know the person at the register. So having this vending machine there makes it more confidential for folks to access those services if needed. We've also worked on a lot of partnerships in those rural areas where people can't access EC. So for example, we are really close to Glacier National Park, and we have a lot of people who come and work at Glacier National Park, and they're 1 hour, 2 hours away from reproductive health care. So we started working with their nurses, dropped off condoms, dropped off emergency contraception. So if those people need to access it, they can do it through their nurse's office right where they're working. And then we also promote advanced prescriptions with our clinical staff. So when they do come in to access family planning services, our providers can write them an advanced prescription to EC. So if they don't need it now and they need it 3 months from now, instead of trying to navigate that, they can just go to their pharmacy and pick it up. So those are a few ways that we're trying to make EC more accessible.
Fantastic. I love hearing about advanced provision of EC, especially Ella. That is such an important option. Stephanie, same question for you. What are you all doing to address the need for EC? Who are you working with, and what makes your program successful?
Yeah, so I guess it was in 2021, in response to SB 8, the Office of Population Affairs, which funds Title X across the country, created a kind of special emergency fund for folks to apply to, specifically to increase access to emergency contraception. And so Everybody Texas received a grant through that effort to fund more access to EC across the state. And so in addition to passing through some of those funds to our current Title X service providers, we did actually partner with a number of abortion funds and abortion practical support organizations who were already delivering this service in their communities. So there were already a number of folks in the state who had picked up this effort and were actually delivering emergency contraception or repro kits with other materials to folks that called and had a need for it. And so we identified those those organizations and partnered with them to give them funding and set them up with more materials and supplies so that they could reach more people and kind of expand their programs a little bit. The other thing that we did as a nonprofit organization that doesn't provide direct clinical services, we established a purchasing account through a pharmaceutical distributor, and we're able to bulk purchase emergency contraception, condoms, personal lubrication. And then we also, through learning that process, we pass that information and opportunity on to those organizations, who some of them now have their own distribution account and are purchasing that way at a discounted cost, which was great, huge thing. And then the other big thing that came out of that effort in that particular funding was, as you mentioned in my intro, our EC for Everybody project. And so Everybody Texas decided to kind of take a cue from the organizations across the state that had been delivering repro kits with emergency contraception in them and start shipping emergency contraception to anyone across the state who wanted or needed it for free. And so the way that works is folks go onto our website, they fill out a pretty brief form, including their address, and we ship them a repro kit that includes 2 doses of generic Plan B, a number of condoms, personal lubrication, 2 pregnancy tests, kind of a guidebook with all kinds of information. Yeah, that's kind of the nature of it. And so the only caveat there for our EC for Everybody project is, and something that we definitely share with folks up front, is that it isn't necessarily intended to work as an emergency intervention. So this project is really about helping folks get it before they need it, so they have it when the need arises, because we can't afford necessarily to ship that quickly across the state.
Yeah, that's great. Yeah, that's really important, an important distinction, because I think, there's telemedicine, there are all kinds of different ways to get EC, but the urgency of getting EC as soon as possible is really an important thing for folks to keep in mind. So we talked a little bit earlier about Ella and the fact that it's a more effective option and why it's more effective, and that it may be particularly more effective for people with higher body weight. How do you see Ella provision playing out where you are? Do you know are clinics in your area providing it, either on demand or in advance? What are some constraints and facilitators for providing Ella in your area? Stephanie, why don't you start that one?
Yeah, sure. So again, as the Title X grantee, we fund about 150 clinics across the state. Many of them offer Ella. I think, it depends on the agency type as to how easily accessible Ella is for folks. What we refer to as kind of our freestanding family planning clinics. These are kind of our nonprofit healthcare clinical providers that specialize in sexual and reproductive health. Those are typically the folks in the state in our network that not only have Ella available to all of their clients, but are usually the ones doing advanced provision kind of on a regular scale. But in addition to kind of what already existed in the network, our team here at Everybody Texas launched a community of practice that is centered around improving access to emergency contraception whole cloth. But a piece of that is dedicated to improving access to advanced provision of Ella particularly, and trying to get providers more accustomed to and increasing efforts to provide Ella in advanced provision way. And so I think some of the constraints or barriers to that is just you mentioned this in your presentation, Kelly, that there's just some outdated perceptions of emergency contraception that still exist pretty, regularly across the provider network. And so part of our goal and part of our role is to provide education and updated training on the provision of EC, kind of all types of emergency contraception, or even, kind of expressed opposition to advanced provision, which is interesting, but it does creep in every once in a while. I think folks are just, I think there's a mentality of it being supposed to be only needed in case of emergency. So why give it to folks in advance? They should be on a method, right? That's kind of the thinking. I think that creeps in sometimes. And so our work has been around education and training to improve access to all methods of emergency contraception, but definitely advanced provision of Ella as well.
Great. Thank you. Mandy, what about you? What can you say about provision of Ella where you are?
Sure. So as a direct service provider, we stock Ella on site with our limited service pharmacy license. So when folks do come in, we encourage our providers to send an Ella home with them or to prescribe it to them, the advanced option. Some things that we're seeing is now that we do have the vending machine and we offer a Plan B over the counter for very low cost or for free, is that folks are using Plan B instead of opting to make an appointment to get the Ella prescription. So it's kind of a catch-22 is that we've made Plan B readily available at our facility. So those folks don't want to take the time to make an appointment. So I'm really trying to do education and outreach efforts on the benefits of using Ella and reminding our practitioners to prescribe Ella maybe over Plan B, because I think they too get stuck on just giving out Plan B and not thinking about Ella. So sometimes when we stock it, it expires because our providers aren't remembering to use that option instead of Plan B. And if we do call in a prescription, very rarely are we finding pharmacies here in our county that are stocking it, because they too say that it expires on their shelves if they do stock it.
Yep. And this is really a chicken and egg problem. You know, we know that a lot of providers don't know about Ella, a lot of patients don't know about Ella. And so if the pharmacies are not seeing prescriptions, they're not going to stock the product. So one thing we recommend at ASAC is that providers, healthcare providers have a relationship with a pharmacy, call a pharmacy in your area and say, look, this is something I'm going to start prescribing more and more to my patients. If you commit to stocking it, at least, have at least one in stock, I'm going to make sure my patients know that they can go to you to fill it. Because it is unreasonable, right, to ask a business to do something that they know is going to lose money. And we don't want to see pharmacies with expiring product. We want to see more people using the best EC that's available. Let's talk a little bit about the response to your program. So what kinds of responses have you all gotten? And, thinking about reactions from the communities that you serve, colleagues in different state agencies, even within the leadership of your own organization, like how have people responded to this? Mandy, why don't you start?
So people within our network and other family plannings within Montana have definitely leaned on us for technical assistance. They reach out just to see how they too can get a vending machine. And I would say we are one of the more innovative clinics that's trying to lead the way here in Montana. So we are trying to get that out throughout our network. The community, people who need EC, it has been such I would say a relief for them, because we will get a phone call and they said, I went to this pharmacy, they either don't have it or they're asking me to pay $65. And when we say, just come in, go to the vending machine, pay $5, you don't have $5, come on up and we'll give it to you for free. It has been a lifesaver for many individuals, and not just adolescents. Like, people think these are, people of all ages who need access to emergency contraception. Of course, some people, like I mentioned, our county commissioners do not like the idea that we are offering EC. We've tried to put out some campaigns to let people know what we're offering within the vending machine, and that you can get it over the counter here at Family Planning. And they have threatened to pull funding. They ask us to take down those advertisements. So it's tricky to get the word out for people who need it, while also trying to do this balancing act, is we don't want to jeopardize the funding that we have available to provide these services.
That makes a lot of sense. Stephanie, how would you answer that?
I think we've seen just kind of nationally, we've actually seen a lot of interest in our project. We've worked with a few other colleagues in the Title X field to help them shape their programs, and some of those are off the ground now as well. I think internally to the organization, again, we're a nonprofit organization, so we don't have many restrictions except for those imposed by state law. And so I think, we've had a lot of positive reaction pretty much across the board. And I think the most interesting thing, and I'd love to share this with you all and the audience today, I've done a couple of surveys of the folks who have requested kits from our program, and just to get a sense of, how they're using their kits, their EC, what they'd like to see, if anything, in addition to the things that we're providing already. And so just to share a little bit of that information with you all, our last survey, I think, closed a little less than a month ago. And so from that survey, we learned that 100% of the folks that responded, they ranked the importance of the EC being available for free as the most important, the highest ranking. So 100% felt like it was very important for it to be free. Almost 70% of the folks that responded said they have already had a need to use the EC that they received in their kit. And then we did get just some kind of qualitative comments on, what this meant to them. And, those are pretty impactful as well. And I'll share a few. One person said, "This kit has saved my life. It feels like considering I'm from a small town with few options and none that are affordable." Another person said, "It is peace of mind. I'm on birth control pill and my partner uses condoms, but with the current state of reproductive rights, I'm terrified of something failing. So it's nice to have extra protection on hand." And then one person said, "It was everything. I was homeless with no job and desperately needed Plan B." And so just to kind of give you all a sense of the folks that are using the reefer kits and EC in our state and from our program, and the obvious pretty dire need for it as well.
Wow, that is really powerful. It's really powerful to hear directly from the people who are being served by the programs in both of your states. And some of those same themes about, what the barriers are and how great the need is. I want to turn a little bit to the future. So what is next for your programs? How do you see it growing, changing, being sustained in the states that you're in? Stephanie, why don't you start that?
Yeah, sure. I think probably something that just kind of popped top of mind. There's a recent article in the 19th that came out. They actually interviewed, I think, Lilith Fund here in Texas about their reefer kit program and the heat. The heat is a huge issue in states where the temperature is really, really high and you're transporting, storing, or mailing things that are sensitive to heat, like emergency contraceptive pills and pregnancy tests. And so I think that is something that has come up for us that we are kind of thinking through how to navigate in the hotter months of the year. I think Austin is having, Central Texas is experiencing the hottest summer on record. And we're going to need a plan. So that's one thing that we're kind of, trying to figure out and think through. But I think more generally, as far as growing the program and its sustaining, we'll be seeking additional funding. I think there's a lot of interest after SB 8 passed, obviously. And then, of course, with the Dobbs decision and the fall of Roe, there was a lot of motivation to fund different programs for accessing contraception and emergency contraception and abortion. And I think everyone in the field is seeing that trend lessen and feeling that restriction and funding. And so I think, that's going to be part of our goal, is to try and fund continued and ongoing sustained funding. And then just more community engagement, more marketing, making sure that we're able, Texas is a big state. We have 254 counties. So trying to reach as many areas and people as we can so that they know about our program or our partners' programs in the area.
Great, thank you. And one thing I talked about how expensive emergency contraception can be in the pharmacy. But it costs less than $1 to make Plan B and generics of Plan B. So a lot of that cost is in packaging, marketing, all those other things. And there are several companies that will sell bulk EC for less than $5. So, many of you have 340B pricing. Like, there's lots of programs that help to make EC accessible. But if you're a nonprofit and you are looking to figure out how to get affordable or even free emergency contraception, please reach out, because we can help with that. We can help put you in touch with the right folks. And this is really for everybody who's on this call. Let's think about, okay, so we've got an amazing audience here of people from all across the country who are probably, lots of wheels turning about what they can be doing in their state. So what advice would you give for, people who are running state health programs and their partners, organizations in the community who want to begin or expand EC access programs? So Mandy, why don't you start that one?
So one thing that I think is really important is to reframe the way you think about emergency contraception. I know when we started bringing it to outreach events and handing it to partners, it felt like we were doing something we weren't supposed to be doing. So just reminding your staff that this is available over the counter and to treat it like we do with condom distribution and bringing it anywhere you would bring condoms. I encourage my staff to bring EC and to provide that education to the community that it's okay just to take an emergency contraception off of our outreach table. Another thing that I think people get hung up on when they're trying to expand really any innovative idea is the fact that they need to collect all this data, they need to engage all these stakeholders, and they need to get buy-in from everyone. And sometimes you're not going to get buy-in from everyone. And I think as a public health leader, you have to challenge the status quo and not take no for an answer. If we would have taken no for an answer at the beginning, we wouldn't have a vending machine. My colleague who was the main driver in getting our vending machine taught me the art of wearing people down. And so they kept saying no, and we just kept coming back, asking questions, bringing information, and not worrying about buy-in from people who, quite frankly, were never going to buy in. And then we did it. And then you realize people get upset for the first couple of weeks, and then they find something new to get upset about. So be pushy and don't take no for an answer.
I love that advice so much. I think that's fantastic. Stephanie, what would you add to that?
Yeah, I would just emphatically like +1 Mandy's effort there, because it's true. You're not going to get buy-in from everyone, but I think kind of in that same vein, in addition to just kind of doing it anyway and asking for forgiveness rather than permission, I think something that we've discovered is that there are a lot of folks out there that are doing this work and getting EC to people who need it. And I think if you are in a restrictive state or in a restrictive area of your state where it's just not possible, or there's too much red tape, too many hoops to jump through, people aren't bending, that there may be an organization in your state that is doing this work that you can partner with and get creative around ideas to get your clients EC if they need it and you're not able to provide it. I think that's probably the biggest thing, but I would say the other part of it is just centering the needs of your clients, especially if you're in a restrictive state. Kelly, you mentioned, the imperative that surrounds emergency contraception and access to emergency contraception, especially in restrictive states. And that if we're centering the clients, then we're going to do kind of everything and all things that we can to make sure they have what they need. And I think to that point, especially if you're in a clinical space working to redraft or implement new policies or standing orders that will allow for advanced provision, those things might not be on your books. And those, I know it's a pretty procedure oriented kind of concept, but sometimes providers won't move unless there's something on paper telling them to. And so I think that's something not to miss, is make sure you're updating and implementing new policies and standing orders around advanced provision.
That's great. Yeah, and sometimes the wonky paperwork is what makes change, right? You've both talked about something that really resonates and reminds me of the incredible work that our student activists do. I'm just thinking of two young people in Texas who are doing this amazing outreach on their campuses, but also in the surrounding community to provide emergency contraception, to provide information about sexual and reproductive health care, to help people know where to go if they need an STI test. And the boldness of these 19-year-olds is just so inspiring to me. And every time I think, oof, like, I don't want to push that, or I think about, like, what would they do? Like, would they be proud of me if I back down right now? And the answer is no, because they never back down. And these are young folks that are they're facing all kinds of obstacles and they're doing it. So we can all take some inspiration from that. And, Stephanie and Mandy both are real inspirations to me. Mandy spoke at our annual meeting 2 years ago, or was it last year, Mandy? I've lost 2 years ago.
Yeah, maybe. Yeah.
I
Lost track.
I heard about this amazing work that Mandy was doing in Montana, and we invited Mandy to speak. Stephanie is speaking at our annual meeting this year, and we're just super excited to let folks know about all this incredible work. We have a few questions that came in through Q&A and the chat, and I want to just answer a few of them. Are there any known efforts to move the efficacy research forward? That's such a good question. There have been some efforts. And I think this question was specifically about the weight and efficacy, whether emergency contraceptive pills in fact are less effective, particularly Plan B, at higher weights. The NIH had a big study that they were trying to launch, and then COVID happened. And so it became very difficult to enroll people. I am really hoping that we're going to be able to get some good results, but right now we may have to live with the data that we have, which means really, in my mind and for our organization, that means always starting with Ella is the most effective pill. IUDs are the most effective option, period. And Plan B is an important option because it's the most available. Somebody asked a great question about offering Ella for advanced provision for folks who are already on hormonal contraception. This is like a whole chunk of my presentation that I cut out because I didn't have enough time. I did talk about this to the medical students last week. So there's evidence that if somebody takes Ella and starts a hormonal contraceptive pill shortly after that it can counteract the effect of Ella, and that can make the Ella not work, and then put the person right back at risk of pregnancy where they were before they even took Ella. So that is a big concern. Again, there's lots of questions about that research, what it applies to, which methods it might be important for. So in the absence of new research, what we recommend is wait 5 days from when unprotected sex happened. On the label right now for Ella, you'll see that it says wait 5 days after taking Ella before starting a hormonal contraceptive method. And we recommend waiting for 5 days after unprotected sex. That can buy you a couple more days, like you can get in a little bit sooner for that new method. And because we don't care, we don't care about sperm after 5 days. So after 5 days from unprotected sex, the sperm are going to be dead. So you don't have to wait those extra days. If somebody is getting an ongoing method, a provider-dependent method like an IUD or an implant, well, IUDs are emergency contraception anyway, right? So they can just come in and get the IUD and not worry about it. If somebody is starting pill, patch, or ring, send them home with the method, have them set a reminder on their phone to start that new method 5 days after unprotected sex, assuming there's no more unprotected sex after that. That's a good question. That's like an hour presentation on its own, but I'm really glad somebody asked about that. And I think that's something that has actually interfered with the growth of Ella, that it's clinically, it's a little bit more complicated to provide. Is there a best practice or restriction on the number of doses that you can give when prescribing Ella? Thinking about STI clinics that aren't currently billing, so coverage is not a consideration. Stephanie Mandage, is there anything you want to say about best practices for advanced provision of Ella? Number of doses?
That's a great question. I don't know that it's something that we've explicitly explored. And I know just from like personal experience, typically a prescription is only given without a refill. And so, I mean, I don't think medical reason for not providing like prescription refills for Ella. So I would say in Texas to my providers, please do.
Yeah. Yeah. And, not only don't just give the prescription and say, fill this when you need it, give the prescription and say, fill it today, even if you don't need it. So that person can have Ella in their cabinet ready for when they need it. The other thing is that Ella will be covered by insurance, right? In the vast majority of cases, it's going to be free for the patient if they have insurance that will cover it. If someone has to buy Plan B from the pharmacy, it's going to cost them a lot of money. So it actually will save the person money, get them EC when they need it, and then they'll have that most effective option on hand immediately. And, as I talked about before, there can be a lot of barriers, even after you have the prescription, finding a pharmacy that will fill it. So if you need to spend a couple days figuring out how to fill that prescription, do it right now when you don't need EC, when it's not an emergency. Do it when you've got time and you're not stressed and you don't have to worry.
Yeah, I want to add something too, Kelly. You kind of jogged my brain a little bit there. Just from a Title X perspective, because Title X clinics are required to offer sexual and reproductive health for low or no cost on a sliding fee scale, I think there are opportune places for folks to access Ella, especially in an affordable way. And I think for those of the clinics in our network and Mandy and across the country that have Ella available, I don't think there's any reason that folks couldn't provide one or more doses at the time of their appointment. So many of these clinics have pharmacies on hand, so they don't really need to prescribe it for an external pharmacy. It's available. The other thing I'll say for clinical providers, something that we do and have added to our monitoring as the Title X grantee is distinguishing when we do a pharmacy review. So when we go on site and do what our required monitoring and oversight of the funding, we're actually distinguishing between the availability of the types of EC that they are holding in their pharmacy, and then making recommendations for them to have both of those on hand.
That's really helpful. Let's see. Oh, yes, we've got a couple questions about mechanism of action of IUDs. So thank you for this. Yes, the slides I was talking about were specifically about emergency contraceptive pills. There is a different mechanism for IUDs as EC. I think, we don't know. There's so much that's unknown about IUDs. And it's very interesting, like as a sort of science-minded person, there's a lot of different ways that IUDs work. I think there is an assumption that IUDs probably can prevent implantation when used as EC. And the reason we make that assumption is because they're nearly 100% effective. So, one thing when we're thinking about emergency contraceptive pills, if they prevented implantation, they would be much more effective than they are. I think the lower efficacy of the pills tells us that there's a missing link kind of in the efficacy chain. IUDs cover that whole spectrum that I talked about. So yes, IUDs as EC can prevent implantation. That's not something that is proven, but it's something that is like a very strong assumption based on the efficacy numbers. How often is too often to take oral EC? Really, safety-wise, I would say there is not such a thing as too often because these are very safe. I would say efficacy-wise, you don't, if all you do is take EC as a contraceptive strategy and you have sex frequently, eventually I think pregnancy is fairly likely. And the distinction is, so the way that Ella works, it delays ovulation. Ovulation will eventually occur with Ella. Plan B can prevent ovulation. It can completely stop ovulation, but Ella tends to more delay it. There was a study that was done. We were really excited about the possibilities of this, of taking Ella on a regular basis to see what it did to ovulation. And eventually a very large percentage of people still ovulated after Ella because it just delays it again. It delays it again. And so if you keep taking it, eventually ovulation will happen. Safety wise, if you take EC pills, a couple times a month, for example, or even a couple times a week, it is going to make your period really unpredictable, spotty. It's just going to be unpleasant, I would say, and you may experience nausea, but I don't think, there's not a safety question. Also, you're not at risk for pregnancy for the vast majority of days of the month. And you know that if you've ever tried to get pregnant, you realize that that window is actually pretty small. So most days in the cycle, EC is not necessary. We do recommend people take it when they're at risk of, when they have had unprotected sex, just because most folks really don't know where they are in their cycle. Let's see. Discrepancy in weight for Ella that may lose efficacy after 196 or 194. Oh, interesting. I have to go back and look at that study and see what the main study finds. Yeah, I don't know why there's a discrepancy, but let's assume, it's in the ballpark right there. That's a great question. Let's see, do we have other questions from the audience right now? I think we might have gotten to the majority of these. Oh, we've got a question about Ella. Is Ella, when I say Ella is covered by insurance, does this include Medicaid? I was thinking specifically about the Affordable Care Act, but I think Stephanie and Mandy probably know a lot more about Medicaid than I do.
Medicaid's been paying for it here in my state, so I know that it does cover it here.
Yeah, I'm pretty sure same in Texas with Medicaid. It's just that any state-funded healthcare programs will not cover it.
Okay. Gosh, we've got a great question that I would love to answer. I know we're almost at time. What are the recommendations for those working in state or government entities to work on getting resources to people without risking funding? I know it was mentioned that in more conservative states, this is an issue. I'd love your thoughts or ideas. Can you each give just a nugget of wisdom?
So one thing we've done, instead of doing mass campaigns where people might hear them, we've really developed an on-the-ground approach. So we have a really robust health education program. So when we do health education, we mention what we're doing with emergency contraception. And then we've developed a network of providers and pharmacists, folks who are friendly, where they can refer them to family planning if they are needing EC. So some of our pharmacists, instead of charging people $60, they'll actually just say you should go to family planning. They're going to offer it for free. So trying to find those advocates within your community that will spread your services in word of mouth is a way to stay under the radar.
And I would agree with that. And I would just add just maybe kind of like referral to the referral. So maybe you're not able to provide emergency contraception in your clinic or area, but perhaps, again, there's someone close by or an organization that's providing it like within the community that maybe you have a brochure for, or a pamphlet or a flyer in your clinic where you're not providing the service, but you are providing information about where that service is available to them.
Okay. I think we could do this all day. I'm going to turn it back to Brittany, who is going to close us out. But thank you both so much. And thank you to everybody who participated today. I'm really excited about the possibilities moving forward. And I'm inspired by everything you're doing in your states.
Thank you all so much. I know I especially learned a ton during that presentation. So really appreciate everyone's time, the presenters for sharing their expertise, as well as all of our participants for joining. As a reminder, this webinar has been recorded. It will be posted on astro.org shortly, and we will email that link as well as a copy of the slides to all registered attendees. As I mentioned earlier in the presentation, this is part one of our two-part series around emergency contraception with Kelly. So keep your eyes out for an email in the fall, winter about our next webinar. And also you'll see on the slide here a link to register for ASTRO's Contraception Access Learning Community's next webinar in September, focus on adolescent sexual and reproductive health. And finally, please feel free to fill out the evaluation for this webinar using the QR code or this link that will also be pasted in the chat. We really appreciate all the feedback that we get from folks about these webinars so that we can continue to improve on them. And as always, if you have questions or want to learn more about the contraception access work that we're doing here at ASTO, please feel free to contact us using this email below. Thank you so much and have a wonderful rest of your day.